and I actually needed an excuse to test out some new equipment and new settings that we have on our internet here to see if we could do a high resolution live stream. So I thought that I would give you a lecture on the meaning of margins in veterinary surgery. There's a lot of discussion about how aggressive we should be with our cancer surgeries with respect to, specifically I'm talking about soft tissue sarcomas, but with respect to how much is too little or too much surgery. And there's been quite a bit of discussion recently as to whether you need to be as aggressive as we once thought we had to be with soft tissue sarcomas. If you haven't already done so, please subscribe to our channel and make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. To get to my presentation here, I'm going to start with a general statement or analogy. Say if you were to go to your human surgical oncologist with a big soft tissue sarcoma on your forearm, like this. And this is what they look like in people, not that different from what they look like in animals. And your surgeon said to you, we can do a really aggressive excision and have about a 5% chance of recurrence in 5 years, or we can do a marginal excision and have an 11 to 75% chance of recurrence in 5 years. And I know which one I would choose, but that's a choice or an option that we have to give to owners when we're discussing these types of surgeries. So I'd also like you to comment on quality of the audio and the visual display, whether we're having any dropped frames or whether the audio is choppy or anything like that. I'd really appreciate it. There's a saying, when all you have is a hammer, everything looks like a nail. And the tendency is that when we do cancer treatment, if all we have is one certain type of treatment available in our practice, that's the surgery, or that's the type of treatment that we often do for our patients. So say, for example, if all we have is surgery available and we don't have a medical oncologist and we can't offer chemotherapy, then we're going to say that every tumor is a candidate for surgery. Whereas if we had radiation therapy in the practice, we might treat our patients a little bit differently with respect to the type of surgery that we did. Or if we had a medical oncologist that could do, for example, metronomic chemotherapy or electric chemotherapy or something like that, again, we might treat our patients differently. So just remember, just because all you have is a hammer in your practice doesn't mean that that's necessarily the best thing for the patient. You might consider what options might be available, including the possibility of referral, or at least a telemedicine consultation to see if there's something else that's offered for our patients. So I'm going to talk to you about the meaning of margins in soft tissue sarcoma surgery, and it's a topic that's very important to me. I do a lot of soft tissue sarcoma surgery, and I've published a lot of cases and stuff. And what I like about soft tissue sarcomas is that their behavior is very predictable if you treat them appropriately. And so even if you don't treat them appropriately, the behavior is going to be fairly typical as well. For example, if you have a large high-grade soft tissue sarcoma and you don't remove it with wide margins, it's almost certainly going to come back. So that is the topic that we're going to be talking about today. So a few facts. Local recurrence implies that the tumor comes back in the same place, and it's the major cause of treatment failure and death following soft tissue sarcoma surgery. The causes of local recurrence, it generally implies that we left cancer behind in the tumor bed, but another possibility of the presence is of what's called skip lesions. So skip lesions are if you did a cancer surgery and your margins were complete, but just outside the margin there were other foci of neoplastic cells. And the issue is that we kind of are starting to think of a cancer bed as kind of a regional phenomenon where if something can happen in one cell, the same thing can happen in surrounding cells as well. So you can have skip lesions. They don't happen as often with soft tissue sarcomas, but that certainly is a possibility. I think we see that more commonly probably with mast cell tumors. So the traditional approach that we always learned in vet school was just wide local excision. And wide local excision is 2 to 3 centimeter margins, and it's interesting to note that the 2 to 3 centimeter margins that are always recommended are really not based on any scientific evidence at all. That was just kind of a catch-all where we thought, okay, if we can convince people to do 2 to 3 centimeter margins, we're likely to get a clean margin and local control in the majority of our cases. But again, certainly in veterinary medicine, that's not based on any kind of research that shows. Basically what we're trying to do is we're trying to guess how far microscopic cells exist beyond the visible tumor. And so if we're saying that 2 to 3 centimeter margins are adequate for all tumors, that means that you're not going to have any cancer cells existing more than 2 to 3 centimeters beyond the visible or grossly palpable tumor. And we know that that approach is actually probably fairly inaccurate. If you have a grade 1 soft tissue sarcoma on an extremity, the invisible tumor cells might exist only a couple of millimeters away from the primary tumor, whereas if you have like an injection site sarcoma in a cat, you could have cancer cells existing 6 to 8 centimeters away from the primary tumor. So that's kind of the catch-all. The catch-all 2 to 3 centimeter margin is kind of a naive approach to cancer surgery. The other option that we can do with a soft tissue sarcoma is a marginal surgery. So what is a marginal surgery? That means that basically you're only cutting out grossly visible tumor and only so you're going just outside the grossly visible tumor. And if you just do that with malignant cancer, it's probably going to come back. The exception to that might be extremity soft tissue sarcomas, which are low in grade. So low-grade soft tissue sarcoma on an arm or a leg, if you, and I'll talk about that more in a little bit more detail, but if you do just a marginal excision, a lot of those are not going to come back. I have a question here. Do you still refer to an oncologist even if the histo comes back clear? Depends on a lot of different things, and I will talk about that in a little bit more detail later on, but that's a really good question, and I'll tell you, if I could answer that question in one slide, I would be very, very impressed with myself, because it is a really subtle and nuanced discussion. All right, so what are the predictors of local recurrence? What are things that are going to tell us that a tumor is likely to come back in the same spot? Well, number one, the extent of surgery. Big surgery results in better local control, and that's been shown, for example, with injection site sarcomas in cats. If you get a 5 millimeter margin, you're going to have half of them back in about 2 months. If you do a 2 centimeter margin, you're going to get half of them back in about 8 months. If you do 2 centimeter margin and radiation therapy, you're going to get half of them back in about 2 years. And if you do 5 centimeter margins without radiation therapy, you're never going to reach a median. Only 14% of those recur. And so certainly with a very aggressive tumor like an injection site sarcoma in a cat, big margins means better chance for a cure. The other thing that's interesting is the surgeon's perception of the completeness of surgical margins has been shown, at least in human medicine, to be as predictive as histologic margins in predicting recurrence. So if you walk out of theater and you pat yourself on the back and think, I've done a really good job here, I never came close to the tumor, that is likely to be a clean margin. Whereas if you feel like you're cutting into tumor here and there, and as you're trying to establish a dissection plane, you see tentacles, that is almost certainly going to be an incomplete margin and almost certainly going to predict recurrence. The other thing that's been shown in a lot of different studies, particularly with soft tissue sarcomas, is the histological completeness of surgical margins, meaning does the pathologist see tumor cells abutting the surgical margin, and that in many cases is going to predict local recurrence. The exception to that would be mast cell tumors, where the completeness of surgical margins does not predict local recurrence. Now, why is that the case? Why are dirty margins not necessarily going to recur, and why are clean margins possibly going to recur? And so the reason is that with histologically incomplete margins, sometimes in the preparation of the sample, you'll have some of the fat that separates and exposes some of the tumor to the ink or to the pathologist, so that they think that it was an incomplete surgical margin when in fact it was complete. The other would be these skip lesions that we talked about previously, where you could have a cluster of mast cells that are growing outside of the primary tumor and in fact possibly outside of the surgical field. So we do have a comment that audio is cutting off intermittently. I apologize for that. I'm getting a drop rate of 0.1% on my on my frames, and so that usually indicates that the live stream is pretty good, but I'd be interested to see if anybody else is seeing any cutoff of any of the audio. And then the next thing that is predictive of local recurrence is tumor size and grade. So the bigger the tumor, the more likely you are to have incomplete margins, the higher the grade. The bigger the tumor, the more likely you are to have recurrence, and the higher the grade, the more likely you are to have recurrence. All right, so again, local recurrence implies that you left residual tumor cells after the excision. So you've left cancer behind. Tentacles can exist a variable distance from the visible and palpable tumor. So if you had, for example, a low-grade soft tissue sarcoma on the extremity of a dog, these tentacles would only exist a few millimeters outside of the palpable and visible tumor. And that means that if you do a margin that's, half a centimeter or even a centimeter outside of that, you're going to get a curative surgery. In contrast to injection site sarcomas in cats, where you can have tumor tentacles extending 5, 6, 7, 8 centimeters away from the primary tumor. And so how can we predict which tumors are going to recur? And remember that local recurrence definitely predicts early death in almost every study. So what are our pitfalls here? So if you do a wide local excision on a narrow tumor, it's potentially overkill with maybe unnecessary morbidity. And if you do a narrow excision on a wide tumor, you might have an incomplete excision with likely local recurrence. And so I knew of a guy that was hunting in South Carolina on his little canoe, and a water moccasin, which is a highly venomous snake, fell from a tree and into his boat. And he took his shotgun and shot the water moccasin, absolutely killed the water moccasin, but it also sunk the boat. And so that would be analogous to doing too wide an excision on a narrow tumor. All right, so what makes a good cancer surgeon? Well, a good cancer surgeon is just good at guessing how far cancer cells exist beyond the visible and palpable tumor. So a good cancer surgeon is just good at guessing how long those tentacles are going to be and then cutting just beyond them. So the objective, if you were the perfect cancer surgeon, would be to cut 1 micron beyond the last cancer cell. And we generally can't predict exactly in vivo exactly where those cancer cells are going to extend to. And so basically we have to use a margin which is wider than our best guess as to how far those tumor cells exist. So it really is just a guess. And what are we going to use to guess? Where we're going to use tumor grade, tumor size, histologic type, things like that, how the tumor palpates, those types of things to try to predict how wide a margin we need to get. So again, how do we predict tentacle length? Where we're going to use histologic type. For example, with soft tissue sarcomas, we know that that's a collection of 5 or 6 or 7 different tumor types that all behave in a similar fashion. So we're looking at fibrosarcoma, malignant peripheral nerve sheath tumor, schwannoma, hemangioperiocytoma, undifferentiated sarcoma, malignant fibrocystocytoma, so several different types. The histologic type of tumor is going to help predict how long those tentacles are going to be. And the reason why I put NPNST here is malignant peripheral nerve sheath tumors tend to be fairly benign, and they tend to be fairly well encapsulated, and they're less likely to have tentacles extending very far. Histologic grade. So histologic grade, we are going to need a biopsy in order to determine that. So if you have a tumor that's in a tough location, it actually might make sense to do a pre-surgical biopsy to figure out what the histologic type is and what the histologic grade is to help us determine how aggressive we need to be with our surgery. What's the anatomical location? So with soft tissue sarcomas, tumors that occur on the extremities tend to be more encapsulated or well enclosed than tumors that occur on the trunk. Palpable invasiveness, so how does the tumor feel? Like, can you move the skin independent of the underlying tissue, or does it feel like it's stuck to the underlying muscles or bones or whatever? And then the other thing that's really handy is sectional imaging, like CT scan or MRI. Now I have a question here. Can you comment on how histopathological assessment of tumor margins in vet med is not as detailed as what is done in humans? It's actually another lecture that I've got, but I can briefly touch on it in that in human medicine, because of the finances involved and the risk and the fact that people are going to live 40 years after surgery rather than 4 years after surgery, they tend to look a lot more closely at the surgical margin, then they'll take a lot more samples than we do in veterinary medicine. Why is that good? Well, with a human sample assessment and preparation, you're much more likely to pick up a dirty margin than you would in a dog, where if you're only taking 2 or 3 samples from the margin, it's conceivable that a tentacle could extend beyond the surgical margin in an area that the pathologist is not looking at. So that's a really good point. Thanks for that. As I said before, CT scan and MRI can help. So generally with trunk tumors, we pretty much universally recommend wide local excision. The reason why we do that, number one, is that they tend to be more invasive, and number two, we usually have more options for primary closure when they occur on the trunk and abdomen, or on the thorax and abdomen. So these are two different types of imaging. The first one is the CT scan, and the second is an MRI. But what I'm really looking at here is this soft tissue sarcoma in a dog. Look how crisp and clean those margins are. So this is likely to be a low-grade tumor. It's probably freely movable. It's completely surrounded by fat. This is just the thoracodorsal blood vessel. So that's not thoracodorsal. That's a deep circumflex iliac blood vessel that's extending into the tumor. So this is well encapsulated, big fat margin, and it's, hold on just a second, it's unlikely to pose a major challenge surgically in getting a clean margin. Now let's contrast that with an injection site sarcoma in a cat. Okay, so we've got this very nebulous looking tumor here in the interscapular space. We've got tentacles extending all the way out to here. That's probably 3 centimeters, and all the way out to here. So that's a tentacle going all the way out to there. So that's probably about 6 or 7 centimeters away from the primary tumor. So if you were to cut this with a half a millimeter or half a centimeter or even a 2 centimeter margin, you're almost certainly going to have, you're definitely going to have recurrence here. And that's what tends to happen with injection site sarcomas in cats. You're much more likely to have recurrence after a suboptimal excision. All right, so what about in extremity tumors? Extremity tumors tend to be lower in grade. My study that I did in 1996 looking at 75 soft tissue sarcomas of the trunk and extremities in dogs showed that the tumors that were on the extremities were definitely lower in grade. The other issue is that there are fewer options for reconstruction. So when we look at our map of axial pattern flaps here, we don't really have a lot of options that extend very far down in the antebrachial region in dogs. In the back leg, you have this genicular artery, axial pattern flap, which can extend down in this vicinity down here, and then you have the reverse saphenous conduit flap, which extends from the ankle up proximally on the medial aspect of the foot that can come down to basically down to the metatarsal region. And so if we have soft tissue sarcoma on the back leg, we're more likely to be able to get a wide excision and more likely to be able to primarily close it with an axial pattern flap. In the front leg, we don't have that luxury. We're not going to be able to, we're not very likely to be able to get an axial pattern flap down there. Also, there's less tissue for primary closure, so the skin seems to be fairly tightly adhered to the underlying tissues. Now, I've got a question here. Today I saw a dog with a 5 centimeter diameter subcutaneous tumor in the neck located on the right jugular vein. My in-house cyto is consistent with spindle cell tumor. It's coming today for a biopsy, or coming in 3 days for a biopsy. So great. And while you have it there for a biopsy, I would recommend getting chest x-rays just to make sure there isn't evidence of secondary spread, because if there's already evidence of secondary spread on a chest x-ray, it really doesn't matter what grade it is. Remember that grade is going to be used to predict behavior, but staging with your chest x-rays is going to tell us how the tumor is behaving in real life, and so that's actually more important almost than grade. So if you have a definitive badly behaving tumor because it's got cancer cells in got tumor growing in the lungs, it doesn't really matter what grade it is. It's already established itself as a bad news tumor. All right, so a couple of studies that came out in a similar period of time looking at less aggressive excision of soft tissue sarcomas in the extremities. So this was Damiano Stefanello in Italy, and he had 35 dogs that they did marginal excision. Marginal excision of low grade, so these are all low grade tumors at or distal to the elbow and stifle. And they followed them for a minimum of 180 days. And I'll submit that 180 days, since the median time in my study, the median time to recurrence of soft tissue sarcomas when it happened was 365 days. That tells us that if you're only following them for 180 days, that's probably not enough, and more of them likely recurred than is demonstrated in this study. So what they showed here was that dogs that had clean margins had no recurrence. Just by way of explanation, this is called a Kaplan-Meier survival curve. This is the probability of survival of whatever event we're talking about. So here it's local recurrence. So the probability of a lack of recurrence, so survival of recurrence. So that's 100% here. And then this is days on the x-axis here. And so what we see is that time 0, none of them have recurred. And then as we go on through time, we can see that the clean margins, none of them recurred. Now, when we look at dirty margins, we can see that 30% of them recurred. So we go back over here to the y-axis. We can see that the probability of survival is 0.7. So that means that 0.3 or 30% recurred. And in clean but close margins, about 20% recurrence. So overall, 4 out of 35 dogs had recurrence, which is 11%. 30% of dogs with dirty margins had recurrence of the tumor. So again, if my surgical oncologist came to me and said, what kind of surgery do you want on your extremity? One that's going to give us a 30% chance of recurrence or one that's going to give us a virtually 0% of recurrence, which one would you want? I would rather be aggressive and be left with an open wound that's going to heal by second intention. I wouldn't worry about the scar very much on my arm, and I know that they've got great reconstructive options both in animals and in humans. All right, so in this study, all of these tumors were low grade. The median tumor diameter was 5 centimeters. 24 out of 35 got dirty or close margins, which was about 2/3 of them. All were closed primarily. They had an 11% recurrence rate. And so let's have a look at the different types of surgical excisions. So this is our tumor sitting here. This first white line is called a debulking surgery. Really has no place in veterinary medicine. It doesn't do us any good at all. If you email me or write me and tell me that you've debulked a tumor, I'm going to be sad. Okay? Marginal excision is when we're going just along the visible tumor margin, so just outside. And this is what they did in this study. 2/3 of them were either dirty or close margins, and 1/3 was a clean margin. Next most aggressive thing would be a wide excision, where we are staying far out of the tumor capsule, giving ourselves a margin of normal tissue beyond what we can palpate and see, and we're also taking a fascial plane deep to that tumor. All right, so this is in contrast to our study, where we had 31 dogs. We did wide local excision on all 31 patients, and we had left them all to heal by second intention. And what was wide local excision defined as was 2 centimeters lateral beyond all palpable or visible tumor, and 1 fascial plane deep. And we had a single dirty margin and a single recurrence, so 3.2%. We cut that dog again, and it was cured. And so out of these cases, 31 cases, we've had 0 recurrences and 0 metastases, interestingly. And so we cured all of these patients, okay, and our median follow-up time was almost 3 years, okay, ranging from 380 days to 2,300 days. Okay, so our follow-up was longer, and we had a lower recurrence rate, suggesting that wide local excision is better for local cure of soft tissue sarcomas. So in our study, again, we had 31 cases. 24 out of 31 were grade 1, 7 were grade 2. So these were even more aggressive tumors than any other study. Our median tumor diameter was 4 centimeters, which is similar. Had 100% clean margins. And I apologize, I said that we had one dirty margin. We did not. We had one recurrence, but no dirty margins. 29 out of 31 healed by second intention. 2 required skin grafts. The median time to heal was less than 2 months. And again, we only had a single recurrence. But look at what we're doing here. We're doing a big excision. That's antebrachial fascia that we're taking off here. And then we're letting this heal by second intention. All right, so what about margin determination? Okay, what we want to do is we want to paint, or we want to ask the pathologist to tell us whether we got a clean margin or not. And what does that mean? It means were there tumor cells touching the surgical margin? Looking at margin determination, completeness of surgical margins is predictive of local recurrence of soft tissue sarcomas. Recurrence predicts early death, and wide excision is more capable of achieving clean margins. Okay, so you know where my vote goes as far as whether we're going to be aggressive or not aggressive with these cases, but you do need to have this conversation with the owners. So there are a couple of special considerations. Oral, high-grade, low-grade fibrosarcomas in dogs. So what are these? These are tumors that grow in the mouths of dogs, mostly golden retrievers. And what they find is that histologically they look low-grade, margins look complete, but the recurrence rate is very, very high with these. About 50% recurrence, 25% metastatic rate, even though they look like they're benign tumors on pathology. So if I have a soft tissue sarcoma of the mouth in a dog, I'm always worried that this is going to be a low-grade, high-grade sarcoma, which means that even with aggressive surgery, it has a high chance of local recurrence. This tumor has the highest rate of local recurrence of any tumor I remove in dogs. The other one that we've discussed in a fair amount of detail is injection site sarcomas. So again, we're going to have to be really, really aggressive with these 5 centimeter margins and 2 fascial planes deep. All right, so what if there's a way that we could predict our margins at the time of surgery? Wouldn't that be the holy grail? There's something in human medicine called Mohs surgery. What they do with Mohs surgery is that they do a thin resection. They send it off to the pathologist and they freeze it, and they can get a margin determination in about an hour. And so this only happens in big hospitals where you have a pathologist on site and you have the capability of doing frozen sections. And then they see where the margin was dirty. They come back and take a little bit more. Send that off. Wait another hour. Come back and take a little bit more. My mother had a tumor on her nose, which was about 1 centimeter in diameter, and her surgery was 6 hours long because they're trying to, again, go that 1 micron beyond that last cancer cell. That's something that we don't really do in veterinary medicine. Number 1, we don't have the patients, and number 2, we don't have a lot of practices that have a pathologist in-house with the capability of doing frozen sections. All right, so there's something else that can be done called optical coherence tomography. I've never used it, but basically what it does is it can read our surgical margins in real time. And so basically you administer a dye and you can look in real time where the cancer cells exist and know exactly what you have to remove. There's also something with indocyan and green that labels tumors that there are some surgeons that are using to try to read the surgical margins in theater. So you cut out a cancer and then you look down at the bed and whatever's glowing green is still cancer, so you go and cut a little bit more there. So that's kind of the holy grail. Problem is that optical coherence tomography only goes a few millimeters deep. Okay, so just a few millimeters. And so we're not going to be able to do really big surgeries. All right, so in conclusion, my approach to these is that recurrence predicts early death, complete margins predicts, or completeness of margins predicts whether or not you're going to have recurrence, but not all tumors are created equal. And so again, if we look at this Kaplan-Meier survival curve, we have 100% survival here on the y-axis and time in months on the x-axis. So the more steeper, or the steeper the line, the more likely you are to have recurrence. So this tumor with clean margins has a lower recurrence rate than these tumors with dirty margins. Is that clear to everybody, how a Kaplan-Meier survival curve looks? And so what we're doing here is we're going to look across the, from the y-axis to that last recurrence, and that corresponds to about 66% recurrence-free or 34% recurrence rate with dirty margins. Whereas with clean margins, we look at the y-axis, comes along at about 83% tumor or recurrence-free, which means 17% of those tumors have recurred. All right, so we're going to use parameters including histopathology type, grade, location, palpable invasiveness, and sectional imaging, if we have it available, to predict how much tumor surgery we have to do to get a cure. And then the other really important thing is informed consent. That is, asking the owners or giving the owners all this information, letting them make the decision as to whether they want you to cut big or little, whether they want you to refer, whether they want to go for radiation therapy afterward, those types of things. So we'll come back to my picture here, and I've got one more question here. Hi Charles, awesome talk, thank you. With the distal forelimb and hind limb soft tissue sarcoma removal, what flexor and extensor tendons can you sacrifice without significant loss of limb function? So great question. With extensor tendons, so the ones that are on the top of the foot, you can take them all out. There's no problem at all because dogs have connective tissue that's going to keep the leg from hyperextending, and active extension of the paw is not a big part of ambulation. It's possible that on the savannas of Africa, a dog that's, a wild dog that's fighting for its food or having to trap its own food is more likely to be at a selective disadvantage without the extensor tendons. But a dog that's just living in somebody's home is going to have no problem with that. Now, what about flexor tendons? So I have removed all the flexor tendons in a few different dogs before. If you take the superficial flexor but not the deep flexor, they're going to walk with their toes. What will happen is that when they bear weight, their toes are going to curl. So it's kind of like what you see when you have a superficial flexor tendon avulsion or damage on your Achilles mechanism, is that they walk where they're plantigrade but that the toes are curled like this. If you take all the extensor and flexor tendons, they're going to walk totally plantigrade like this on the toes. So the ankle or the hock or the carpus are still going to be intact. It's just going to be the toes that are going to be walking down on that metacarpal pad. If it means that we're going to be able to cure the tumor, I'm happy to do that. Probably be more likely to do that in a young dog, like a 5-year-old dog that has a higher chance of recurrence because it's just going to be around for a longer period of time. So more likely that that tumor is going to recur. If I had a 12-year-old dog, I might be more likely to use a less aggressive surgical excision or a marginal surgical excision. All right, so I'm just looking at my chat here. That's pretty much all I have to say, but I'll wait around for a few minutes. If you have any more questions, please stick around and go ahead and ask them. And if you're interested in seeing what other questions people might have, stick around and have a listen. Otherwise, I will see you guys again soon. Hopefully, I'll be live streaming surgery tomorrow. All right, any other questions? All right, so we'll go ahead and leave it at that. We'll wrap it up. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And please leave comments on the quality of the transmission, quality of the audio, so I can see if I can fix anything in the future. Thanks.